Thank you. I sincerely appreciate the opportunity for, on behalf of me and my colleagues and certainly our hospital to be part of the symposium. I'd like to thank the president of Saudi Heart Failure and the organizers of this most excellent meeting. And today I want to address the novel therapies of acute decompensated heart failure. Just briefly about our institution, we're nestled in the Texas Medical Center, a large clinical operation with over 1,000 beds, and our heart failure group really represents the academic mission for the hospital in terms of disease management, in addition to end organ assessment for consideration for transplant and devices. And really a part of our main initiative is education, research, in addition to excellent clinical care. So I sincerely appreciate the opportunity to spend some time with you all throughout the course of today. My specific aim as it relates to identifying novel therapies for acute decompensated heart failure are discuss medicines of high interest with some focus on serelaxin. I will briefly go through the ultrafiltration story. Certainly CARES trial was mentioned in the first talk as it relates to the use of device therapy in the setting of renal syndrome with volume excess and increased creatinine. And I will briefly discuss ongoing device trials. And as mentioned earlier today, and certainly in the United States, acute decompensated heart failure, most importantly for our patients, is staggering because it certainly defines the morbidity of being in the hospital, defines the morbidity of this syndrome. And unfortunately, despite improvement in medical therapy over the last 10 to 15 years, still an event rate as high as 1 out of every 3 patients being admitted to the hospital or dying. And the cost for us are staggering, and 2/3 of the $25 billion annually are attributed to the management of patients in the hospital. We've adopted really from the underlying pathophysiology that defines chronic heart failure, in that certainly with neurohormonal activation, alteration of the cardiorenal axis, this accounts for the hemodynamic changes that defines the sine qua non of heart failure, and that's elevated filling pressures to account for the breathlessness and the signs of volume overload. And while we have not clearly defined the true mechanism of acute decompensated heart failure, we've extrapolating from these known underlying physiology in terms of using medicines that have helped us. Now, this is a busy slide, certainly, and I want to focus in on areas of research in the context of affecting this syndrome, and we'll spend some time in terms of the outcome metrics that I think are the most important. Serelaxin enhances nitric oxide synthase and augments nitric oxide, which lends to smooth muscle vasodilatation, and I'll go through its detailed effect. Uridatide is part of the family of natriuretic peptides, and unique mechanism in terms of similar effects in terms of vasodilation and natriuresis. And I won't spend much time as it relates to the other potential pathway altering medications as illustrated. When you take a step back and look at the acute decompensated heart failure trials over the last 10 to 15 years, in large part, they've been relatively smaller trials, perhaps with the exception of ASCEND heart failure in the use of niciritide, and Everest in the use of tolvaptan. One of the criticism has been that the endpoints chosen, certainly for niciritide, relate to hemodynamic surrogates of worsening heart failure. And while certainly the FDA has positioned us to be very clear about what it means at the patient level in terms of dyspnea as a surrogate and/or weight change as a surrogate of alone may not tell the whole story. In the United States, loop diuretics, certainly the mainstay, as mentioned earlier, for treating this syndrome, date back to the physiologic premise in terms of how it works pharmacokinetically. Similarly, inotropes, in terms of their hemodynamic effects, have helped. And when we looked at niciritide, which received approval in 2001 on the basis of hemodynamic import, while it was encouraging, these trials had some improvement from secondary surrogates. When we look at larger trials and taking into consideration the niciritide story and most recent ASCEND heart failure published in the New England Journal in 2011, when you look at harder endpoints like all-cause death or rehospitalization, which again defines the morbidity and mortality of this syndrome, there's really been no medication, let alone niciritide, that has had a meaningful impact in this regard. And it is on one hand, it is reassuring that patients don't have the worsening renal function that we were concerned with, but there is a concern about hypotension when using these medications that have more overt vasodilatory action. In 2010, adenosine alpha-1 receptor antagonism was examined based on the underlying premise about preserving glomerular filtration rate, enhancing sodium excretion, and improving diuretic responsiveness. But again, another disappointing result in that the primary endpoint of treatment success, no change, or treatment failure compared to placebo versus the use of raloxifene really demonstrated once again that there was no improvement or medication, certainly at that time. Astronaut, perhaps one of the more recent studies published in JAMA in 2013 as a direct renin thrombin antagonistic based medication, patient population that was reasonable in terms of a little over 1,600 patients, striving for a primary endpoint that's meaningful, reduction in cardiovascular death or heart failure. But unfortunately, the continued message, no difference in cardiovascular death or heart failure hospitalization when compared to placebo. Now, serelaxin, I want to spend some time over the next few slides. It's a recombinant form of human relaxin-2 vasoactive peptide hormone, which is known to mediate the hemodynamic changes that occur in pregnancy. It accounts for the uterus and cervical expansion, and it accounts for some peripheral vasodilatation, which prevents women that are pregnant from having overt heart failure. And in terms of its mechanism, as mentioned earlier, it enhances nitric oxide synthase, and through nitric oxide, it leads to systemic and renal vasodilatation, and it inhibits sodium reabsorption and is associated with augmented natriuresis, both very important potential physiologic responses to this peptide. Serelaxin has many potential very good effects in terms of not only the reduction of myocardial overload, but reducing inflammation, minimizing oxidative stress, and there's some animal work in terms of its extracellular matrix remodeling that's been associated with minimizing fibrosis. Now, in the mid-2000s, this drug was actually being studied in the United States in patients with scleroderma to demonstrate whether there was a reduction in its antioxidative properties and minimizing fibrosis. And while that was negative in a subgroup of patients, it was noted that patients with scleroderma and heart failure, they had a significant improvement in their clinical heart failure state. And so Novartis got involved in this company, and this was at the time of the phase 2 investigation, where in over 200 patients, there was a hint of using parental relaxin at 30 micrograms per kilogram per day, a reduction in cardiovascular death or admission, again, the more meaningful endpoint in patients with heart failure. Relax acute heart failure was a phase 3 trial, prospective, double-blind, based on the dose response findings from the phase 2 trials using 30 micrograms per kilogram per day of serelaxin, international-based study with an important primary endpoint evaluating dyspnea, including two. Patients report of an improvement based upon a visual analog scale, and importantly, the percentage of patients with moderate or marked improvement at 3 time points within 1 day. And as published in Lancet by Tierlink and colleagues, while the visual analog scale area under the curve was associated with a difference in comparing serelaxin versus placebo, really at these 3 pre-specified time points, 6 hours, 12 hours, and 24 hours, there's really no significant difference in terms of patients having moderate or marked improvement. Now, it is very intriguing from this trial, while there was no difference in cardiovascular death or heart failure hospitalization, as evidenced by this Kaplan-Meier curve, placebo in blue, serelaxin in red, p-value of 0.89. Cardiovascular death alone, there was a hint or signal, if you will, that there was a reduction. This was voted on by the FDA in May of 2014, actually 11-0 against approval. On one hand, it's rare for the FDA to approve a drug based on a single study. While we've seen an exception in the context of Entresto and LCZ 696, that's most probable in the context of how big that trial was and the survival advantage demonstrated. And this study failed to meet both its primary dyspnea efficacy endpoints. On a positive note, as referenced in the FDA report, this medication may affect harder outcomes in a meaningful way. So there are two phase 3 trials underway. Relax Heart Failure initiated October 2013, a 6,800 patient multicenter study, meaningful endpoint examining 6-month mortality and worsening heart failure at 5 days, and in a Asian-driven multicenter trial of a little over 1,500 patients, examining the efficacy of serelaxin as it relates to improvement in signs and symptoms of heart failure. So keep on the outlook for these two trials. Now, urodilatin is an important human natriuretic peptide that is part of the natriuretic peptide family, and it's been chemically synthesized, and it has been noted to have significant beneficial effects as it relates to vasodilation and natriuresis as highlighted in this mechanism. There have been 2 phase 2 trials, CIRRUS-2 being one of those, and very intriguing hemodynamic data with the use of this medication with significant reduction in left-sided filling pressure, improvement in systemic vascular resistance or vasodilation, and improvement in cardiac output. True advanced acute heart failure is a randomized, double-blind, ongoing study, 200 centers, including North America, Europe, and Latin America, anticipated to have enrollment of over 4,300 patients, and looking at 2 co-primary endpoints, again, as it relates to worsening heart failure within 48 hours, and looking at CV mortality throughout the duration of the trial. I think it's important to keep in mind this backdrop of dyspnea as it was in the serelaxin story and as it was demonstrated in the nicertide story, but this is one of the trials to keep an eye on. Briefly, ultrafiltration, we use at our institution as part of our armamentarium to treat patients with refractory volume excess. It's different from dialysis in that it's up to 33, 35 cc's of blood that passes through this polysulfide filter and delivered back to the patient. And you can dial in the rate, for example, 200 cc's per hour, to reliably remove up to 5 liters over a 24-hour period. And we've learned in the context of what is the mainstay of treating acute decompensated heart failure that diuretics actually activate neurohormonal systems and increase plasma renin and increase plasma aldosterone, which define the underlying pathophysiology in part of this syndrome and are the opposite effects that we like to see. So perhaps a diuretic holiday, if you will, can be associated with potential improvement. Different from diuretics, ultrafiltrate from blood is isotonic, so that the amount of sodium that you're removing per unit of fluid is much greater compared to loop diuretics. This slide summarizes the breadth of data as it relates to ultrafiltration to date. Unload trial put this device, preliminary results put this device on the map, at least in terms of further investigation. It was a 200-patient study looking at weight loss and dyspnea as a primary endpoint. CRESS was mentioned earlier. And in the Unload trial, while there was significant reduction in weight, actually dyspnea compared to standard of care, and that's loop diuretics, there was no difference. But intriguing data in a pre-specified secondary endpoint as it relates to those that had ultrafiltration, a greater percentage of these patients were free from re-hospitalization. And so the ACC/AHA guidelines that was updated in 2009, where it was a class 2 level of evidence B recommendation, then higher than what we've had for many interventions we use to treat patients with this syndrome. And more recently, in the context of CRESS, ultrafiltration is a 2B and may be considered with refractory volume excess. And in the cardiorenal syndrome, defined as persistent volume excess, creatinine greater than 0.3 milligrams per deciliter increment while treating these patients, ultrafiltration, as mentioned earlier, bivariate endpoint of serum creatinine at 96 hours and weight and body weight was not proven to be efficacious compared to pharmacologic therapy. In fact, there were signals of increased adverse events. And so as I mentioned, we use this in those with refractory volume overload. And when we compare it in terms of cost effectiveness to what we have at our armamentarium, it is associated with increased cost in terms of the lifetime purchase of the device. And importantly, filters for us, it costs $900 per filter, and it could be efficacious if you're using it in those patients that are associated with recurring remission, long length of stay. If you can get away with 1 or 2 filters, it can be helpful in cost saving. So I've reviewed a few novel treatment targets. I think testing strategy is going to be important for this field. Certainly dose was one of those trials that was landmark in terms of low versus high dose and intermittent versus continuous. Chloretic trial will examine the effect of thiazide diuretic plus loop diuretic. Its design has been recently published in the Journal of Cardiac Failure. And earlier trial to examine the use of pleuronil, which has been very helpful in stage C patients with systolic heart failure, EF less than 40% as a survival advantage in those chronic patients, is being examined in terms of initiation during the acute decompensated heart failure episode. And in the context of using biomarkers in that 30% reduction, really tailoring intensification to pro and BNP is going to be under examination. I think when you take a step back and look at the trials to date, they've been smaller-based studies using secondary surrogates in terms of endpoints. The reality is that we want to curb mortality, we want to minimize readmission, and we want to do it with the shortest length of stay. And the number of patients needed to power the study appropriately remains a challenge in this heterogeneous patient population. So in conclusion, acute decompensated heart failure trials based on novel therapeutics have overall been disappointing. There remains an unmet need for developing new agents to curb really what defines the syndrome, the morbidity and mortality. And ongoing phase 3 trials to look for over the next, what I would estimate 1 to 2 years, include serelaxin and urodilantin. And the ultrafiltration story, I think it's still helpful for select patients that have refractory volume overload. I appreciate your attention.